Hello, and welcome to the Postpartum Years Podcast. I'm your host, Dr. Ellen Kramp. I'm a physical therapist and a pelvic health specialist. Joining me today is Dr. Shirin Towfigh. She is a hernia specialist. She is a surgeon working out of Beverly Hills, California. So welcome, Dr. Towfigh.
Thank you so much, Mary Ellen, for inviting me, and happy to share whatever knowledge I can to help your audience.
You are a hernia specialist, so how about we start out by defining what a hernia is?
Okay, so I'm a general surgeon by training, board certified, and my specialty within that specialty is hernia care. So anything related to hernias. A hernia is, broadly speaking, it's a hole within usually a muscle or fascia, often in the abdominal wall, although you can have hernias elsewhere, much more rare, much less, very, very uncommon to have it elsewhere, but you can. The concern with hernias is that that hole shouldn't be there or is too large, and therefore it can entrap a vital organ, let's say an intestine. That's not common. Much more common if you have, let's say, fat in there, which is not as, lethal. And then it's dependent on someone like me, the hernia surgeon, to determine, if you have a hernia or not. And sometimes it's not obvious if someone has a hernia. They can just present with symptoms, but not the actual bulge that you may see with most hernias. And then B, determine the plan of care. Do you just watch this or do you need surgery? And then a bulk of my work is actually treating patients that have already had some type of surgery and need more help. So they either have chronic pain or a complication, something as simple as a recurrence or something as complicated as a mesh infection or nerve injury or mesh erosion, and any kind of permutation of those things.
Okay, since we are dealing with the postpartum years here, what are common postpartum hernias that you see?
Well, this is a great topic because very little is written about postpartum and peripartum abdominal wall issues. We do know that the most common abdominal wall issue postpartum is diastasis, which is a thinning and separation between the rectus muscles. So the rectus muscles are like what we often call the six pack, right? The abs in the middle of the belly. And as you can imagine, those there's a left and a right. And when you have a baby grow in you, your belly needs to expand, and those muscles also pull apart from each other. And in the ideal situation, when you're done having a baby, everything goes right back to where it belongs. And we know that in many women that occurs, and they have no issues with their abdominal wall. In a very strong fraction of women, however, they get a separation. So that muscle never comes back to its normal position. So now you have kind of your muscles, which are part of your core and the strength of your abdominal wall and your back and everything that kind of holds you straight and protects your spine and everything else that comes with your breathing. Those muscles are no longer in a straight line. They're kind of pushed to the side, and it can have consequences. So there's some guidelines as to what exactly defines a diastasis. A general rule of if about an inch or more wide, so about 2.5 centimeters or more wide between your muscles, that pretty much is the structural definition of a diastasis. And then men and women can both get it, honestly. It's very genetic. So there are women that have had 5 kids and they have perfectly flat belly. And there are women that have 1 child and they still look pregnant. So when your muscles are separated, you no longer have that flat look to the abdomen. You have a more of a rounded look. And part of that is the separation of the muscles. And part of that is also when you're separated from a physics standpoint, the forces are not aligned to kind of hold everything in together either. So technically, we don't consider a diastasis a hernia. There's no hole. It's a thinning, but it does have consequences. So one consequence is, like I mentioned, the kind of the core imbalance, which can cause back pain, constipation, pelvic floor dysfunction. Because you kind of lose your abs, so to speak. The second consequence is because the midline thins out, hernias that would not otherwise occur in the midline, like a belly button hernia, can now occur because it's much easier to tear a thin tissue than a thick tissue. And then if you ever need surgery, something as big as like a big trauma surgery or abdominal wall surgery, or something like laparoscopic surgery, right, where we think, oh, it's just little holes. If you put those incisions where this thinned out area is, you will get a hernia as well. So there's a lot of kind of downstream consequences with having a diastasis besides the look to it.
Yeah, I see diastasis recti a lot
Yeah.
in my practice, and I find about 50% I can, by doing different mobilizations in different areas, a lot of times there's a lot of tension in the back, and that's kind of preventing everything from coming together. And since connective tissue also has contractile property to it, neurologically that can get shut off and then and tend to just kind of be sitting there kind of floppy. And it's so satisfying to watch that get turned back on and the muscles just come together. But with some people, it seems like there's just a lot of damage to that connective tissue. And I was being my nerdy self and doing a lot of research and trying to find, at what point does that diastasis become what's called a ventral hernia, where it's suddenly a hernia. And I couldn't find any consensus in that.
No. So there is not that much consensus in our world either. So my world as hernia surgeons includes mostly general surgeons like me, but we also are doing a much better job nowadays than before in integrated plastic surgeons into our world. So there is a cadre of plastic surgeons that do a lot of abdominal wall or hernia related surgery. In the past, it was very disparate. So general surgeons like me would do hernia surgery, and then plastic surgeons would do tummy tucks. And when they do a tummy tuck, sometimes they'd see a hernia, they'd fix it. And when we do a hernia surgery, sometimes we see a diastasis and either ignore it or fix it. So now we're doing a much better job of coordinating the two specialties into like a common line in terms of how we treat patients. We are much better at understanding the role of diastasis in reconstructing the abdominal wall. So, for example, in my practice, and I'm in Beverly Hills, right? I'm Beverly Hills Hernia Center. So I believe the Golden Triangle in which my office is the largest concentration of plastic surgeons in the world. And that comes with a lot of pros because I get to work with plastic surgeons and I also get to learn from them, and we share a lot of patients. And so that's been a really great part of my practice, which is integrating plastic surgery concepts into abdominal wall reconstruction and hernia surgery. So let's say you have instead of a 1 inch, you have a 2 inch, like 5 centimeter diastasis. That's a good size diastasis. That's going to make you look about 5 months pregnant, 4 or 5 months pregnant. Unfortunately, we have no good data that shows that any type of physical therapy is going to address that. The best data that I know of is one paper that very religiously took patients through a very coordinated physical therapy program. And the best they can do was bring the diastasis closed by about a centimeter.
Mm-hmm.
Like I said, 2.5 centimeters is kind of where you start talking about a diastasis. So a 5 centimeter diastasis taken down to 4 centimeter. The only way to cure a diastasis, unfortunately, is either you're really fit and your abdominal wall is constantly contracted to make up for it.
Which I will say causes more problems.
Right? Yes.
Further on down the line.
Yeah, you're totally right. Or you have surgery to artificially sew those two muscles back together. Some people know that as a tummy tuck. When done in the face of a hernia repair, we call it a diastasis plication or ventral hernia repair or abdominal wall reconstruction. There's different ways of talking about it. But as many of you know, our health system is pretty dysfunctional. And to this day, diastasis closure is not considered a hernia repair and is considered cosmetic. And we all know it's far from a cosmetic problem.
Yes,
Yes.
I know.
Yeah.
Okay, so full disclosure, I did have actually an incisional hernia from my C-section. It split apart when I stood up after having my
Oh my.
youngest, and
Early post-op.
the next morning,
Oh my.
the first time I stood up, and there were two residents that I didn't even know at the time had been a part of it was a crash C-section. So I was under general anesthesia,
Yes.
and I didn't even know they were in the room, but they were the ones who actually sewed that up. And, it was on their very first
Well,
rotation.
it was not your first
So
C-section, right?
that was probably their first. Yes.
It
And
was your first C-section.
it was my first.
It was your
It was,
first.
yeah, it was my third child, but it was my first C-section. It was a
Oh
cord
my
prolapse.
goodness.
So it was, we need to do the C-section now. And she's born 10 minutes later. So it was very, very, very fast. And so I didn't even know there were residents in the OR, and they were the ones who, my husband was allowed in because he's also a physician. So he was the one who told me that they sewed me up, and but he was paying attention to the baby. He wasn't paying attention to what they were doing, and I don't think the OB was paying attention to what they were doing. And as soon as I stood up, it split apart, and it took me 25 years to try to get a physician to pay attention to me that there was something wrong.
Oh my. Yeah.
So I just last year had it repaired, but I was being told I had one plastic surgeon. Oh, you don't have a diastasis. You don't have a hernia. You don't. There's nothing wrong here. And then I had another general surgeon tell me, nope, you don't have a hernia. There's nothing wrong. And he had sent me for a C-section or a CT, and I'm looking at the CT and I can see bowel between the muscles.
Yeah.
And because I knew of a surgeon in Sarasota by one of your podcasts, I consulted with him, and he's like, you've got a 15 centimeter long hernia.
Oh my God. Okay, let me explain this. This is very important. Like I mentioned earlier, technically, a diastasis, which is a thinning of the tissue, is not a hernia because there's no hole. Now, you can have an incisional hernia, right? Like you had, right? They made an incision and it busted open. So you can have an incisional hernia that on imaging looks like not a hole through which things are going, but like a thinning of the tissues. And that's just a misrepresentation of what's going on. So, for example, I see patients, not uncommonly, that they had an incision, right? And it was sewed. And they tore it open, but not enough for it to bust open. It just kind of pulled apart. And they probably scarred that in, right? Your body tries to heal that. Then it pulled apart again, and they scarred it. That's got scarred. They pulled apart again. That's got scarred. So you now have a pulled apart wound at the muscle level, and basically just thin scar holding everything else in, which is very thin and not functional. And so on imaging, it looks like there's a layer there and not a busted open hole. And so the radiologist will always call that a diastasis. Technically, it's an incisional hernia, not a diastasis means you've never had surgery before. Your muscles, either genetically or which is more common in males, or because of like a pregnancy, which we see in women, got pulled apart. But the native tissue is still there. It's just there's no muscle anymore, so it's thinner, relatively thinner. That is not an incisional hernia, but on imaging they may look similar. So what happens is your doctor has good intentions and sends you to, let's say, a CAT scan, and the radiologist says diastasis. The doctor that ordered the CAT scan looks not at the image, which will definitely show a hernia with bowel, like your case, with bowel going through it, but they'll look at the report that says diastasis. And that misread report will haunt you until you find someone who actually looks at the image, because it's not a diastasis. And we've been trained, because insurance has trained people, that diastasis is cosmetic, it's not a hernia. Not true. And therefore, they're like, oh, it's just a diastasis. Just live with it. Maybe wear a Spanx or something, wear a binder, it'll be fine. And that's completely incorrect. So we are slowly getting better at that. But I must say, it's not become common practice yet to look at your own imaging and determine what this random diastasis where the C-section scar is, uh, and B, to treat diastasis as part of your abdominal wall reconstruction. I've learned to do it. We're teaching more and more surgeons to do that. It's a much better hernia repair if you fix a hernia and address the diastasis within which it's residing. But it's more work. It's more work for the same pay, so to speak, because insurance will not understand the diastasis plication or support part of it, but it's better for the patient.
Yeah. Yeah, it's driven me nuts over the years to hear that diastasis is a cosmetic. When I have patients that, constantly have pelvic instability, constantly have back pain, and once they get that repaired, that goes away. And I mean, I can keep working on them. And
I don't think people understand when we say core, right? We may think of, people that are online teaching you how to do like sit-ups and planks and all that. But the core is so much more than just your abs, right? The core is your six-pack, it's your obliques, it's your back muscles, it's your pelvic floor muscles, and it's your diaphragm. So that entire box from diaphragm around the abdomen down to your pelvis consists of the core. And one imbalance in your core, whether it's your back or your front, pelvic floor, or even your diaphragm, will mess everything up.
One thing that goes along quite often with the diastasis, especially because I will see sometimes all the way from the ribs down to the pubic bone, that the abdominal separation is there all the way. And frequently there's an umbilical hernia in the middle.
Yeah.
Now, at which point is that necessary to repair?
First of all, a lot of women have an outie. Like during their pregnancy, they have a little belly button sticking out.
Tells you when the baby's done.
All right. Men have it too, but if you see it during pregnancy, that's an umbilical hernia. And sometimes it actually closes back up after delivery of the baby. But the question is, when you fix an umbilical hernia, which is a belly button hernia, with a diastasis or without a diastasis. So it's more common to have a belly button hernia if you have a diastasis, because like I mentioned, that tissue gets thinned out and then is more likely to be able to tear. Any outie is an umbilical hernia. Until proven otherwise, 90 something percentage of people that you see with an outie, it's actually an umbilical hernia. And some people think that's cute, but I think everyone deserves an innie. No, if you have an outie, get it fixed. Give yourself an innie. But the question is how to fix an umbilical hernia when you already have a diastasis. So an umbilical hernia or an outie in someone that doesn't have a diastasis is a very beautiful operation. It's a cute little incision right in the belly button. You just dunk in that little hernia and you stitch up the hole. You don't need to use mesh. If it's larger, so more than a centimeter or two wide, so about half an inch or more wide, then you should consider doing a little bit more than what I just mentioned. And that could be done open, laparoscopic, robotic. There are techniques without mesh. Once you hit 2 centimeters, you really should use mesh. Then the question is, okay, now let's make it more complicated. Now you have this outie or umbilical hernia, but it's sitting in this thinned out tissue. So if you just close that like you do any other person without a diastasis, those stitches won't hold because you're putting stitches through very thinned out, unhealthy tissue, and it'll just break open again. So the options are address the diastasis and throw in the hernia repair as part of it. That's usually a tummy tuck. Tummy tuck technically is closure of the diastasis with any hernias as well. plus removal of the
the
thinned
excess
out
skin.
skin. So it's like really 2 operations in one. The closure of the diastasis can occur open, like a plastic surgeon would do, big incision down low, pull down the extra skin, long recovery time, really good cosmetic result. We are now doing these laparoscopically or robotically, so you don't have the second portion of the operation, right? You just deal with the abdominal wall closure. It's much easier recovery. There's no huge wound to heal from, 3 little incisions in the bikini line. You can't see it. And we close the diastasis. But if you have a lot of thinned out or extra skin, don't choose that option. I think cosmetically it doesn't look good. It's not worth your time. So I would spend the extra energy to get a full classic tummy tuck by a plastic surgeon if you have loose skin. And then if you close the diastasis at the same time as a belly button hernia, that belly button hernia repair is much better. Now, you can also kind of be in between, right? You can do the belly button hernia repair and not address the diastasis, but do a better job at the hernia repair. So either use mesh or do like multiple sutures instead of just a single line. So there's like the Mayo technique and these other types of extra techniques that I use and other surgeons may use to close the umbilical hernia, understanding that it's not like doing a full tummy tuck, but it's better than just a simple umbilical hernia repair.
I know a lot of people are afraid of mesh.
Yes.
And I try to counsel my patients through that and try to, kind of bring that fear factor down a bit. Because I know there were problems, especially in the GYN community with mesh many years ago.
Yes.
Can you, because I know there are people who have like an autoimmune reaction to mesh, but can you explain who should be wary versus, the general population who really shouldn't be quite as wary of it?
Yes, absolutely. So mesh as we know it today was developed back in this like late 70s, 1970s. So we've been using mesh for decades. Mesh today is much more advanced than it was in that we have polypropylene mesh, polyester mesh. We have completely absorbable meshes that are either synthetic or biologic. So you can get it from human cadaver. Skin has been turned into mesh. Sheep's stomach has been turned into mesh. These are all absorbable. And then we have this hybrid situation where you have this mostly absorbable component with some synthetic kind of permanency from like standard mesh together into one. So the issue with mesh is it's a foreign body. The same way a pacemaker is a foreign body and a hip implant is a foreign body and a breast implant is a foreign body. Therefore, your body needs to be accepting of this foreign body. Cataract lenses are foreign bodies. So every foreign body has its risks. The safety that we need to take care of with mesh is number one, it has to be placed in kind of a clean system because any foreign body can get infected, and most foreign bodies that get infected do not fare well. They have to be removed. You've heard of people with like pins in their feet or hands or knees or hips that got infected. That's a big deal to have a joint implant infected. The same is true of abdominal wall mesh. You need to be cognizant of does a patient need a mesh or not? A lot of patients don't need mesh. Smaller hernias don't need mesh. Thin people or low risk people are less likely to benefit from mesh than larger people. So you got to make sure you have the right patient. Then the second is what type of mesh. So they come in different weights: heavyweight, midweight, lightweight, ultra lightweight, and then they come in different absorbency, like fully absorbable, partially absorbable, or non-absorbable. So, for example, I would never put a really thick heavyweight mesh in a yoga instructor or ballerina, right? They tend to be very, very thin and need to maintain a lot of flexibility. So unless it's a disaster situation, you would choose either a non-mesh or like a lightweight mesh situation in those. And where you place the mesh is very important too. So the deeper around the muscle you put the mesh, the less they're likely to feel it and the better it performs because it's kind of does its function without you feeling it. You don't want mesh around critical organs like intestines. And the women, they were putting it around through the vagina or around the urethra where you pee. Bad idea. And we learned from that, right? And when mesh was invented, they didn't know this initially, like in the 70s. And it wasn't until the 80s where they figured out maybe we shouldn't be putting mesh directly on intestine. There needs to either be put in a different plane, like around the muscles, not around the intestines, or we need to kind of make sure the mesh is made of something that doesn't stick to intestines because it doesn't erode. Same way the mesh eroded into the urethra, we knew it does erode into, like, let's say, bowel. So because of the type of practice I have, like I mentioned, I do a lot of revisional and hernia complications. I see a lot of women because I'm one of few women that are actually in this specialty. I've seen that we have now a new complication with these implants, which is a reaction to the actual material. So the same way you can be allergic to certain clothing, certain rubbers, latex, you can be allergic to certain foods. You can also be allergic to the mesh product. That's a disaster, right? If you put in a product in someone, you do this perfect surgery, and then now they're sick from it because they either have a big rash or even worse, they start getting joint pain and like autoimmune disorders, like they lose their hair, they start seeing blurry vision, they get this brain fog, memory issues, tingling in their fingers and nails, weird rashes all over their body. Those are reactions to the mesh. Very uncommon. I see a fair number of them. We actually published about this. And it's called mesh implant illness. You may have heard of breast implant illness, as it's all the same family of things where you're reacting to an implant because of the inflammation or like autoimmune. In an ideal world, we would have better meshes that you are just inert, but that's not how mesh works. Mesh works by adding inflammation to the body and having that inflammation spark a healing kind of cascade. We don't know who will react to meshes. We just don't know. There's no blood test. There's no perfect scenario where we're like, you will definitely react. But we do know those that do react and have mesh implant illness tend to be women, tend to be younger, tend to be super thin, like underweight. About 80% of them tend to have an autoimmune disorder themselves, like they have lupus. It could be lupus and rheumatoid arthritis, or it could be vitiligo and other kind of less appreciated autoimmune disorders. And or a very strong family, like mom has rheumatoid arthritis and aunt also has lupus or psoriasis. And I would be careful about putting mesh in them. Now, the majority of those patients will still do fine. But if you were to choose what population is more likely to react to meshes, it would be that population of people that already have a heightened inflammatory state in their body and kind of an autoimmune tendency.
So let's talk about other hernias that are out there as well, because I know I see in my practice a lot of hypermobile patients. So they tend to
Yes.
have a diastasis, they have prolapse, and they have hernias everywhere. So it's more than just the midline hernia. I've seen the inguinal hernias and also elsewhere in the abdominal wall as well. I've caught a couple of those as well.
I would say physical therapists, especially specialists like you that are pelvic floor physical therapists, are amazing at this because you actually are hands-on with the patient and you can tell all these different types of hernias and these different types of dysfunctions. And the patients with the hypermobility, hyperflexibility syndromes, the most extreme being Ehlers-Danlos syndrome, but there's like a spectrum. Those patients are very challenging to treat because they likely have a genetic collagen disorder, connective tissue disorder, but we think it's collagen mostly. And so they're prone to any ligamentous laxities, right? Their knees and shoulders like pop out the socket, and they can do all these funky things with their fingers that I'm definitely not. I'm very unflexible. But their elbows can hyperextend, and if you ask them, they've had multiple joint problems, etc. So hernias by nature have less collagen or more of the immature and less of the mature collagen than the native tissue. And if you have a patient that already naturally has that collagen disorder, then you can't treat them like the standard hernia patient because they will be lax no matter what you do. So in my practice, I have a different protocol for patients that are hyperflexible. They get very tight repair. They get a lot of plication. They kind of get like a quote tummy tuck every time they have any type of hernia repair where their tissues are tightened more. They often benefit from mesh. Mesh doesn't stretch, and it adds that extra layer of stability to your tissue repair. They can get hernias anywhere, and often have multiple hernias, and have pelvic floor dysfunction at the same time, where they have the looseness and prolapses and so on, and a lot of laxity and hernias in the groin area, which is where the inguinal hernia comes. So I have a whole protocol about how to treat patients with true collagen disorders, connective tissue disorders like Ehlers-Danlos syndrome, where you tighten up the muscles and you add mesh. And interestingly, their pelvic floor gets better. Their pelvic floor symptoms get better after you fix their hernia repair. It's interesting how the body connects that way. There's one very specific scenario, though, that we still don't have a great solution for. And that is patients with Ehlers-Danlos syndrome that also have associated syndromes. So they have mast cell activation syndrome, they have endometriosis, they may have small intestinal bacterial overgrowth, they may have POTS, which is postural orthostatic tachycardia syndrome. But it's like this genetic,
all of the above.
All of the above. So
that's half my patients.
But besides making that a more complicated patient, specifically patients with MCAS, the mast cell activation syndrome, they're allergic to everything. Putting mesh in them can be a disaster. So I either don't put mesh in them, or I use the hybrid mesh that I talked to you about, where it's mostly like an absorbable, very low inflammatory cadaver tissue. But that doesn't work for patients with Ehlers-Danlos syndrome. So now you have Ehlers-Danlos and MCAS in the same patient. And I haven't figured out how to ideally treat those patients. We don't have any good system for them.
Ooh, yeah.
But less is more. Less is more with them. Less is more.
Yeah. Yeah. But they need some stability at the same time. And
they really do.
And I know the answer to the next question that I get all the time is, I want to have another baby. Do I get this repaired? Or, what happens if I get pregnant after I get this repaired?
We'll do the easy one first. So groin hernias, inguinal hernias, get it repaired whenever you have problems. It does not affect your pregnancy. Most women who are pregnant do not have inguinal hernia problems. So don't worry if you have an inguinal hernia, then you want to get pregnant. You'll have a fine pregnancy, and it won't. The inguinal hernia or the groin hernia will not interfere with your pregnancy. So don't stress out about the inguinal hernias. It's really not anything that relates. You don't really expand in the groin area. What you do expand is the mid abdomen, right? So the question is, a female with a umbilical hernia, and they're fertile and want to have more kids. In general, we do not recommend any umbilical hernia repair or any kind of abdominal wall hernia repair until you're done with pregnancy. And the reason for that is there's a good chance you'll pop the stitches and have a recurrence. And that number is in the 20-30%. It's not 100%. It's like 20-30%. You may have pain during your pregnancy because you're trying to tear open the stitches. And that could be horrible, because then it may be debilitating pain, right? You may need even narcotics, or it's just painful, especially towards the end, like the last trimester is when you really stretch. Because you're done like doing the usual stretching, and then beyond that, it's when it gets kind of painful, that last trimester. If you do get a hernia repair with mesh, remember, mesh does not stretch. So you're now stretching an abdominal wall, but part of it doesn't want to stretch. And so you can get chronic pain from that area trying to stretch and it can't stretch. Or you can, again, bust that open. Lastly, if you do have like a major abdominal wall reconstruction, let's say, unfortunately, you were in a bad car accident and like a lot of abdominal injuries, and you need to have a huge abdominal wall reconstruction with a big piece of mesh placed. And a lot of people who do hernias, infertile women, don't really have this discussion, which is the implication of a hernia repair with pregnancy. Then you may actually be in a situation where the abdominal wall will not expand much. And it may make your intrauterine growth a little bit, slow down, maybe smaller baby. I'm not sure. We really, listen, I'm telling you this without really any data that no one studies it. No one studies it. No one publishes it, but we do believe that if you can live with your belly button hernia or even your diastasis, don't fix it until you know you're done with all pregnancies. So I ask my patients, you want to have more children? I don't know, maybe. Okay, come back to me when it's an answer is
Sure.
strong. Now, have there been women who've had full tummy tucks and then had a pregnancy? Yeah, and they do fine. They may have busted open their tummy tuck, so that's a waste of a lot of money down the drain because now your belly is back to square one. Now, we do want to make sure the females get adequate care. So if you have a hernia that bothers you, it hurts you, it's painful, it's affecting your ability to concentrate at work or pick up your baby or whatever, you should get it fixed, right? That's a quality of life improvement. And just take your chances about what happens during your next pregnancy. But in general, for belly button hernias, we say wait until you're done with pregnancy and then come back and consider a good, strong, definitive repair. One last thing I'll say is a lot of women have a belly button hernia or a outie during their pregnancy, and they are sent to me by their obstetrician during their pregnancy or shortly after birth. Do not get any surgery in the abdominal wall, whether it's a tummy tuck or it's a belly button hernia repair, until all your hormones are back to normal. Because during pregnancy, the progesterone really allows you to expand. And if you're breastfeeding after a pregnancy, those hormones are still circulating and your muscles are not back to their normal strength. So a good rule of thumb is do not contemplate any type of abdominal surgery for at least 3 months after you're done with pregnancy and or breastfeeding. So if you're not breastfeeding, 3 months after pregnancy. If you are breastfeeding, 3 months after you're done breastfeeding. So that will give you a better outcome surgically.
What tests should be ordered to see if somebody has a hernia?
Yeah, I mean, a standard ultrasound is the best, cheapest test. Most ultrasounds should give you the answer of whether you have a hernia or not and what size it is and what's in it. Those are the 3 things we want to know. Yes or no hernia, what size, and by size we mean the width of the hole, and what's the content? Is it fat or is it intestine? It could be bladder. You can have an ovary in a hernia. And then if an ultrasound is not adequate and the hernia is clearly visible, then a CAT scan is just as good. If the ultrasound is not adequate and you think you want more information, let's say it's indeterminate or you want other questions answered, MRI is a much better test. So of all these tests, MRI is better, but it's claustrophobic, it's more expensive, it's not as readily available throughout the world. So ultrasound is usually better. In the United States, we don't do a good job of ultrasounds for hernias. They're much better done, outside the US because they do so much more. So I would say ultrasound first. If it gives you your answer, you're done. If it doesn't give you your answer, but you feel like you want more information, I prefer MRI. Some people go to CAT scan because it's easier to read, but it often is not good for the really small or very kind of nuanced hernias.
Yeah, because women can have the smaller
Yeah.
hernias and have a bunch of symptoms, but no bulge present.
Yes. We call those occult hernias or hidden hernias. And one of my favorite papers I wrote got published last year called Hidden Hernias Hurt. And it's because the women show up and they have pain in the groin, in the pelvis, in with sex, with orgasm sometimes, any type of intercourse. They have bladder issues and bloating and so on. And they're dismissed. And all this because there's no obvious bulge. No one says it's a hernia. The same patient, a male, would have a bulge usually, and they'll say, "Oh, you got a hernia. Let's fix the hernia." In women, that's not true because our inguinal canal is narrower. We tend not to have as much large hernias. Um, so you present with a lot of pain and delay in diagnosis. Lots of narcotics are prescribed, and your pain level tends to be high. But an MRI is very good for that. If an ultrasound doesn't show a hernia in those patients, it has to be a hernia ultrasound, not just a regular ultrasound. Then I would just jump straight to a pelvic MRI. And if you go to my Beverly Hills Hernia Center website, I have that MRI protocol in the patient section. You can just download that, take it to your radiologist or to your doctor and have them order it exactly as I wrote it, because that's a good study.
What do you suggest is the best way for a person to find a good surgeon for hernias? Because I
Oh,
know you guys aren't all created equal.
okay. Well, you have different resources. I have a website called herniatalk.com. It's a free patient discussion forum. Just sign up, and there's like 10, 12 years worth of discussions about hernias. And people do name their surgeons there, or you can ask, like, who was your surgeon? I live in Connecticut. Who do you recommend? So that's one way. I also have my own podcast, which is Hernia Talk Live. And on Hernia Talk Live, I do interview other surgeons, and they can be hernia surgeons. They could be, actually, I should say other surgeons, other practitioners, because I've had other physical therapists and orthopedic surgeons, pelvic floor specialists, etc., gynecologists. But specifically, the hernia surgeons that I interview, I stand behind. So if I interview Dr. Spy in New York, in Long Island, then and you live in that area, then yeah, go see him. He's a great doctor. I don't by rule interview anyone that I don't respect. So that's kind of like a cheating way of finding out who to go to. The American Hernia Society does have a find a surgeon portal. So you can just go to the American Hernia Society website and go put in like your state, for example, and see who is a American Hernia Society member. That doesn't mean that they're good or that they even are a specialist, but does at least mean they're interested in hernias. So you can start from there as well. And you know what? A lot of us do offer consultations to people outside of, you don't have to come and see me. I do offer like a kind of like a cursory online consultation opportunity. Just send me your information. I'll just email you what my thoughts. It's not like I'm your doctor, but I may say, "Oh, you're in Wisconsin, and why don't you go see my friend Dr. So and so, and they can take care of you. And this is what I think is going on." So there is that opportunity for some of us offer that.
Great. Is there anything else you would want patients to know?
Be your own advocate. Always get a second opinion. I say that every single time. Even if you see me, I think I'm pretty great. All I do is hernias. But you know what? You should get a second opinion. I've had surgeries of my own, and I literally know the surgeon. I think they're the best surgeon for my need. I still went and got a second opinion because the questions you ask and the way that someone else sees your problem is just enlightening. And people just say, it's just a hernia surgery. No. There's so many decisions that go into that. And women especially are not as well represented in the hernia surgery world. And so most surgeons don't really understand how to treat women different than men. And they just treat you as if you're like a male, and your symptoms may be different or your hernia may be different. So always get a second opinion.
I really, really appreciate you coming on the podcast and
Thank
everything
you.
that you shared.
Thank you. I hope it wasn't too much information all at one time. If there is such a thing.
I mean, you share a lot of information on your podcast too.
Yes, thank you.
All right. So I hope that was helpful to everybody out there. And thank you very much. We'll see you next time on the Postpartum Year podcast. Bye.